Good morning, everyone. I'll start in just a couple of seconds. It looks like people are able to log in, and we can get this going. All right, being 9:01, I'm going to kick this off so we stay on schedule. Welcome to the New Hampshire Insurance Department's annual hearing on premiums and the insurance market. I'm Christopher Nicolopoulos, and our hearing is an opportunity to present the findings from data submitted to the department and to create a public forum on related issues. This has been an interesting year for a lot of reasons, but I'm happy to say that New Hampshire continues to do well compared to many other states across the nation. In addition to the Gorman presentation on the data carriers have submitted to the department, we'll be hosting 2 carrier panels today. The department has just relaunched our health cost website, but that's just one of the recent developments in the area of price transparency. After almost 15 years of hosting the health cost website, we're happy there continues to be strong demand for the information we provide. Our panel on price transparency will explore the benefits and challenges further. New Hampshire has successfully implemented the 1332 waiver, and that has resulted in lower premiums in our individual market. We have 3 carriers supporting the consumers in this market, and our premiums are among the lowest in the country. Our small group market cannot be ignored, though. Like most states, New Hampshire has seen a reduction in lives covered through small employers. Both federal and state rules are intended to protect consumers in this market, but we may need to look at options in New Hampshire to increase the stability and viability of the insurance products long term. Our carrier panel focusing on this market will explore the unique characteristics of the small employer coverage. Some housekeeping before we dive in. Today's event is being recorded and will be available later on our website. All participants have been muted to preserve the quality of our audio during this hearing. After the first presentation and during the carrier panel, participants can use the chat feature included here in Teams to submit questions. If you have comments but not questions, please wait to the public comment period at the end of the hearing. Please reserve the chat function for question submissions only. First off, I'd like to recognize the staff from the department who played a key role in setting up today's hearing. Tyler Brannon, Lisa Cota-Robles, Andrew Demers, Tiffany Fuller, and David Sky. I'd also like to recognize the team from Gorman Actuarial Partners, including Jenn Smagula, Don Gorman, Emma Rourke, and Linda Keene. First, we'll hear from Jenn Smagula, representing Gorman Actuarial. We have sent people who've registered for this hearing a link to her preliminary report. The report, as well as the 2-page summary, are available on our website. A final report will be released in early December. The 2 carrier panels will follow the Gorman presentation. I'd now like to introduce Jenn Smagula, presenting findings from the data submitted to the department. Jen?
Thank you, Commissioner. I am going to go ahead and share my presentation. Okay. So we are going to get started. So again, yes, I'm Jenn Smagula. I'm a healthcare actuary working with Gorman Actuarial. I'm joined today virtually. Oop. Is my Andrew, is my camera on?
Well, I don't see you sharing your screen, Jen.
Oh, you don't? Okay, sorry. Let me try that again.
There we go. Much better.
Okay, and you can see my video too?
I don't see your video, but I see your slide up full screen.
Okay, maybe I'll just try one more time before I give up on that.
Your video was on there for a second, Jen.
Okay, maybe I have to Okay, so I think the video and the presentation is up now.
Just the video.
Sorry. Okay, so I think the presentation is up, but not the video.
That's right. And I think we can proceed this way.
Okay, sorry about that. Okay, so I'm Jenn Smagula. I'm a healthcare actuary working with Gorman Actuarial, and I'm joined today virtually with my colleagues, Don Gorman, Linda Keene, and Emma Rourke. And I'm going to take you through this presentation on the key findings from our 2020 preliminary report on New Hampshire's healthcare premium and claim cost drivers. So the goal of the report and presentation is to examine health insurer premium and claim costs and the factors contributing to changes in those costs. And this year's focus is on 2020, but I'll also be presenting available information from 2021. Now, this slide gives an overview on where New Hampshire residents received their health insurance in 2020 based on information collected from the Census Bureau's current population survey. So it's important to note that this is a different data source than what we used in our prior reports. In our prior reports, we used data from the American Community Survey, but this data was delayed as a result of the pandemic. So the CPS data shown in this year's report cannot be compared to the ACS data from the prior year's report. So of the 1,367,000 total New Hampshire residents, approximately 843,000 or 62% of residents in New Hampshire receive their insurance through private commercial insurance, either through their employer, which is that 57% in blue, or by purchasing coverage on their own, which is that 5% in purple. Medicare coverage is the next largest coverage category at 21% in red, followed by Medicaid, which is the 11% in green. Now, these next couple slides compare the New Hampshire average premium to the average premium from other New England states and to the US average. This first slide looks at the individual market using publicly available data from the CMS risk adjustment reports. Average premiums in the individual market decreased about 2% in 2020, following a significant decrease in 2019. Now, the decrease going from 18 to 19 was driven by the transition of the New Hampshire Premium Assistance Program enrollees from qualified health plans on the exchange to Medicaid plans. Now, when we look at this data into 2021, we expect to see decreases in the average New Hampshire premiums due to the Section 1332 waiver state-based reinsurance program, which started on January 1st, 2021. Across the United States, which is the average in the red line, the change in average premiums was fairly flat from 18 to 19, and again from 19 to 2020. And when comparing New Hampshire to the average in New England, New Hampshire's individual market premiums of $535 are about 13% lower than the New England average of $615. Now, note that Vermont and Massachusetts are not part of this average since they have merged markets. New Hampshire's actuarial value, which measures benefit richness, is consistent with the other New England state average, and the New Hampshire risk scores, which measure morbidity, are slightly lower. This chart takes that same data used in the previous slide and shows New Hampshire's average premium in the individual market, which is shown in red, compared to all the other states. So as shown, New Hampshire's 2020 premium ranks 15th lowest in the country in the individual market. And this is consistent with where they ranked last year. They were also at the 15th lowest. This slide looks at the small group market using that same publicly available data from the CMS risk adjustment reports. New Hampshire small group premiums, the blue bars, remained close to the United States average in 2020, the red line. Average premiums increased about 3% in the US in 2020 and about 2% in New Hampshire. The average premium in New England, the green line, increased about 4% during the same time period. New Hampshire premium continued to be lower than the New England average by about 8% in 2020. Now, New Hampshire does have lower risk scores compared to the average of New England in 2020. So in the small group market as shown here, New Hampshire's 2020 average premium ranks 19th highest in the country. And this is also fairly consistent with where they were last year at the 17th highest. So we know the median age in New Hampshire is the 2nd highest in the country. The median income is the 9th highest in the country. And education levels are also the 9th highest in the country. So all these factors can lead to higher than average premiums. Now this slide compares large group average single premiums in New Hampshire to the United States average and to other New England states. CMS risk adjustment does not apply to the large group market, so we do not have that same data available to us. So here we're using data from the Medical Expenditure Panel Survey, or MEPS. The United States average is shown in black and New Hampshire is shown in red. And the other New England states are shown in those other colors. So this shows that in the large group market, New Hampshire is consistently higher than the US average. Now, when compared to other New England states, New Hampshire's relative position has fluctuated over time. And in 2020, they currently have premiums on the higher end compared to the other New England states. And note that these premiums include both the employer and the employee contribution. So now we're going to move on to talking about coverage shifts. And by coverage shifts, we mean we're looking at shifts in health insurance enrollment by market segment, by insurer, and overall. So this first slide gives an overview of the New Hampshire Citus commercial insurance market from 2017 to 2020. And by New Hampshire Citus, we mean that New Hampshire has jurisdiction over the policy, which in turn typically means that the employer is headquartered in New Hampshire. And by commercial, we mean people who are purchasing insurance on their own or receive coverage through a New Hampshire employer. On the left-hand side, we have this gray bar that shows the proportion of membership within each commercial market segment in 2020. Now, similar to prior years, about 90% of commercial coverage was purchased through an employer-sponsored insurance arrangement, or ESI. So this consists of the small group market, the large group fully insured market, and the large group self-insured market. Now note that over half of the commercial market, or 55.7% of folks, are enrolled in the large group self-insured segment. Now the right side in color shows enrollment by market segment for each of the 4 years. Now looking at the top, we have the individual market, and we can see that while there was a significant decline going from 17 to 18, it has remained fairly stable with a slight increase in 2020. The small group market, we've seen since 18, some small but steady declines. The large group fully insured market, we've seen slight declines. And in the self-insured market, we've seen slight increases. But overall, membership in total is fairly stable from 18 to 2020 with some minor changes. Now this slide drills into the small group market membership from 2019 to 2020 by insurer. Now in prior years, we've seen that Tufts Health Freedom Plan, which is shown in purple, had increased their market share significantly after entering the New Hampshire market back in 2016. But it looks like at this point they've stabilized and there's a slight decrease in their market share going from 2019 at 21% to 19% in 2020. And note that as of January 1st, 2021, United Healthcare owns the Tufts Health Freedom Plan. So in future reports, these two companies will be combined for reporting purposes. United currently has 1% market share in this segment, and that's been fairly consistent for the past several years. During the same time, Anthem, Matthew Thornton, which is shown in blue, has lost some small amount of market share, while Harvard Pilgrim in red has gained some market share. Now in the individual market, Ambetter, which is shown in orange, has continued to increase their market share. They went from having very little presence in the non-PAP segment back in 2017, and they grew to 22% in 2019 and further to 27% in 2020. And while Anthem, Matthew Thornton's market share has fluctuated from year to year, they were currently at 68% in 19, dropping to 61% in 2020. Harvard Pilgrim's market share is fairly stable, but they did increase slightly going into 2020 and are at 12% market share. And both Ambetter and Harvard Pilgrim pointed to the introduction of on-exchange bronze plans as part of the reason for their growth into 2020. So up to this point, we've been looking at enrollment through 2020, but this slide compares fully insured membership from April 2020 into April 2021. So here we see an increase of about 4,000 enrollees in the individual market. Now, the individual market experienced several changes in 2021. First, as we mentioned previously, New Hampshire's Section 1332 waiver state-based reinsurance program started on 1/1/21, helping to lower premiums in the individual market. Second, the American Rescue Plan Act of 2021, or ARPA, temporarily expanded eligibility for premium subsidies and increased the financial assistance to those who already qualified for subsidies. And lastly, there was a special enrollment period in 2021 that extended the deadline for enrollment to July 31st, 2021. Now, the large group population experienced a small increase in membership going into 2021. They're up to 105,000. And the small group saw a decline going from 65,000 down to 63,000 in 2021. So a loss of about 2,000 members. This slide shows a more long-term view of enrollment data for the individual and small group markets. So through the annual hearing data collection process, membership is typically collected as of April and December of each year. And this year and last year, we also collected membership as of July 19, July 2020, and July 2021 to understand more recent enrollment changes. Each dot on these charts represent a data point, and the small group market is shown in red and the individual market is shown in blue. So between April 2016 and July of 2021, small group enrollment has declined 14%. And after remaining fairly stable in 2018, that's where we start to see the decrease pick up more in the small group market. It goes from a little under 70,000 enrollees in December of 18 down to 64,000 enrollees as of July 2021. Now, the individual market shown in blue is more volatile, and what we typically see is a decrease in membership from the start of the year to the end of the calendar year. So you see that back in 16, April to December. You see it again in 18, from April to December, and so forth. Now, as we saw in the previous slide, here you can see again the increase in enrollment into 2021, and the individual market is currently, well, as of July 2021, it's right around or a little above 55,000 enrollees. Now, this slide takes that individual market enrollment and breaks it further into 4 pieces. We have the non-exchange segment in red. So this includes enrollees in ACA plans who purchase them off exchange, but it also includes the grandfathered and transitional enrollees in this segment, and they represent about 3,000 enrollees in 2021. The purple line represents exchange enrollees who are above 250% of the federal poverty level, who are eligible for advanced premium tax credits, or APTCs. The green line are exchange enrollees between 138 and 250% of the federal poverty level, and these are folks who are eligible for both APTC and cost sharing reduction subsidies, or CSRs. And lastly, we have the blue line. So those are exchange enrollees who are not receiving any types of subsidies. So again, New Hampshire introduced their state-based reinsurance program as of 1/1/2021, and this lowered premiums by 14% on average. So between April 2020 and April 2021, we see that the enrollment in the non-exchange segment has increased by about 1,200 members. And in the blue line, the exchange non-subsidized, they increased by about 4,300 members for a total increase in these segments of 5,500. So these enrollment changes were most likely due to the reduced premiums from the reinsurance program. Now, these increases are somewhat offset by a decrease in the subsidized population, the green and purple, by about 1,300 members. Now, in addition, ARPA temporarily expanded eligibility for premium subsidies for those over 400% of the federal poverty level. So we do see that New Hampshire experienced a slight increase in the exchange population with greater than 250 of the federal poverty level, this purple line. We see a slight increase going from April to July. And not shown here, but we know from the New Hampshire Insurance Department's exchange monthly enrollment reports, there was an increase of an additional 1,600 enrollees going from July 2021 into September 2021. Consistent with the individual and small group markets shown on the previous slide, membership is typically collected as of April and December for each year for the large group markets. And the last 2 years, we also collected membership as of July to understand more recent changes. Now, this slide shows the large group fully insured segment in red and the self-insured segment in blue. And we have membership here from April 18 to July 2021. The self-insured segment had increased slightly between April 18 and April 2020, but then decreased by 5% or 14,000 enrollees going from April to July of 2021. One insurer experienced some large losses, citing furloughs, layoffs, and a leave of absences due to COVID, along with the loss of one larger group as contributors to these declines. The large group fully insured segment has remained fairly flat, and there's just been a slight decline over time. This chart compares New Hampshire CITES enrollment and New Hampshire Medicaid enrollment for December 18 to July 2021. And again, by New Hampshire CITES, we mean employers who are based in New Hampshire, but their employees may live outside of New Hampshire. Total commercial enrollment is the combination of those four segments we just looked at in the previous slide. So individual, small group, large group fully insured, and self-insured. And we can see that total commercial enrollment has not changed much, but there is a slight decline going from 499,000 to 489,000. The Medicaid enrollment is coming from the New Hampshire HHS website. So these data show that enrollment started increasing in April 2020 and has continued to increase into July of 2021. Between December 19 and July 2021, Medicaid enrollment grew by 45,000 enrollees. So one question we've asked, or you might be asking, is where are the Medicaid enrollees coming from? So keep in mind that the commercial enrollment we're looking at is for New Hampshire situs, not New Hampshire residents. To be eligible for Medicaid in New Hampshire, you must be a resident. We know that there are a large number of New Hampshire residents who work for Massachusetts employers, and that the Massachusetts unemployment rate is higher and continues to remain higher than New Hampshire. And as of May of 2021, the Massachusetts unenrollment rate was 6.1, while in New Hampshire it was 2.9. So one explanation may be that there are New Hampshire residents who work for Massachusetts employers who have lost their health insurance and now qualified for Medicaid in New Hampshire. Another explanation is that in many states, HHS has not been redetermining eligibility for Medicaid since the start of the pandemic in March of 2020. So we're only seeing growth in the Medicaid population, and we're not seeing any declines or any disenrollments. And lastly, some of these Medicaid enrollees may be coming from the uninsured population. This slide takes the New Hampshire individual market exchange membership and examines their metal level in 2019, 2020, and 2021. The metal level represents a plan's actuarial value or benefit richness. Generally speaking, bronze plans have lower premiums and higher cost sharing, while silver and gold plans have higher premium and lower cost sharing. So for members on the individual market exchange in New Hampshire, there was a slight shift away from silver plans to less rich bronze plans going from 19 to 2020. Now from 2020 to 2021, we see that the percentage of enrollees in gold plans has increased from 6 to 10%. So this may be as a result of the reinsurance program that started in 2020. The premium reductions allowed some enrollees who otherwise may have chosen a less rich silver plan or bronze plan to be able to afford a more rich gold plan. Now, this chart does not include catastrophic members, which represents less than 2% of the exchange membership each year. This slide, well, we're moving on to talking about premium and cost sharing. And this slide gives a picture of what happened to premiums in New Hampshire over the last 3 years. The average fully insured premium in New Hampshire increased 1.2% in 2020. The small and large group premiums increased 2.2% and 1.5% respectively, lower than the trends that we saw back in 2019, the 4.3 and the 4.1. So one reason for the lower premium trends in 2020 in the group markets is due to the COVID-19 premium credits from some of the insurers that were given out in 2020. The individual market decreased slightly at minus 0.8%. Now note again, this is 2020 data, so prior to the start of the state-based reinsurance program. Premium levels, or the PMPMs in the individual market, have stayed fairly close to the levels in the small group market, so 526 versus the 530. And based on the 2020 Employer Benefits Survey from the Kaiser Family Foundation and the Health Research and Education Trust, in 2020, average premiums in the employer market across the country increased about 4% for single coverage and 4% for family coverage. So the New Hampshire trends are lower than these trends. This slide looks at the premiums and premium trends in the different segments within the individual market. And keep in mind, this data is shown prior to the impact of any federal APTC subsidies. So as we just saw, the overall premium in 2020 decreased by 0.8% compared to 2019 for the individual market. And each of these segments within the individual market, premium trends were low in 2020. The largest segment within the individual market is the exchange population, and they had a trend of minus 1.1%. Now, the grandfather transitional population experienced the highest increase back a year ago in 2019 of 10.4, but they've come down a lot, and they're trending at 1.5% in 2020. And just keep in mind that this grandfathered and transitional population is a small and shrinking population, and it's not part of the single risk pool. So that's why it's shown as a shade instead of a solid color. So now we're looking at average cost sharing in the New Hampshire commercial markets. So the bars here represent the cost sharing PMPMs, and the boxes going across the top represent cost sharing as a percentage of total allowed costs. Member cost sharing includes costs paid by members in the forms of deductibles, co-payments, and co-insurance. In 2020, cost sharing PMPMs decreased in all segments compared to 2019. This was most likely due to members utilizing less services and a change in the mix of services due to the impact of COVID-19. Another contributory factor is that some services like COVID testing and other COVID-related services had their cost sharing waived in 2020. On the left-hand side here, we have the individual CSR population. So these CSR subsidies allow lower income individuals to have lower deductibles, copays, and co-insurance while still paying fairly low premium levels. So these members pay some of the lowest amounts in cost sharing at $62 PMPM, or 12.3% of total allowed costs. So this is much lower than the cost sharing paid by everyone else in the individual market, which is labeled individual non-CSR. So in this segment, members are paying about $100 per month in 2020, which represents close to 25% of their total allowed costs. And we see here the large group self-insured segment continues to pay the least amount in cost sharing at $48 PMPM, or 9.2% of costs in 2020. In this slide, we're pulling together all the info we just looked at from the past couple slides and showing the relationship between premium and benefit richness in 2019 and 2020. The paid to allowed ratio on the y-axis, or the vertical axis, is an indicator of the richness of a health insurance plan's benefits. So the higher the ratio, the more rich the benefits and the less members are paying out of pocket. The x-axis, or the horizontal axis, is the average premium PMPM. Now, each bubble in this chart represents a market segment. This chart maps each segment's benefit richness, or paid to allowed ratio, compared to their premiums. The shaded circles represent last year's results, 2019, and the solid circles represent this year, 2020. So enrollees in the individual market who received cost sharing reduction subsidies, up here in the green, have the richest benefits in the market because they have paid to allowed ratios in the upper half of the chart. By contrast, the enrollees in the individual market who do not receive CSRs, which is down here in blue, have the least rich benefits in the market because they are in the bottom half. So looking from left to right, this, generally speaking, benefit richness increases as the premium increases. to this point, all of the premium information we have looked at was through 2020. This chart looks at the change in the second lowest cost silver plan in the individual market from 2018 to 2022. Rates and rate changes for the second lowest cost silver are commonly reported, as this is the plan that represents the benchmark plan from which federal premium subsidies, or APTCs, are calculated. But keep in mind, this is only represents one plan, and the insurer offering the second lowest costing silver can change from year to year. The change in the second lowest cost silver plan from 2020 to 2021 is minus 18%. So as discussed, the rate decrease in 2021 is due in large part to the start of the state-based reinsurance program in 2021. The rate change going to 2022 for this plan is minus 7%. And when you look at the cumulative change from 2018 to 2022, it's a decrease of 35% from 18 to 2022. This slide shows an illustrative example of what a 40-year-old non-tobacco single policy holder in New Hampshire would pay for the second lowest cost silver plan and the median bronze plan in 2021 at various income levels under the subsidies in ARPA, or the American Rescue Plan Act. So as explained previously, ARPA increases the financial assistance for those who already qualified for subsidies. So that's everyone up to 400% of the federal poverty level. And in addition, it expanded eligibility for premium subsidies for those above 400. So in this chart, these last two sets of bars. Now, $333 is the full premium for the second lowest cost silver plan in 2021. And $277 is the full premium for the median bronze plan. So while ARPA does provide subsidies for incomes over 400%, the subsidies only come into effect after the enrollee pays the premium cap, which in this case is 8.5% of their income towards health insurance. 8.5% of the enrollee's income in this example for a 40-year-old is higher than the actual premium for the rates for the second lowest costing silver and the median bronze. Therefore, there's no subsidies provided for this 4-year-old. They're paying the full premium. For older individuals, 8.5% of their income may be lower than the actual premium rate. And in those instances, they will or they may receive subsidies. Now, on the far left, we show members with FPLs between 133 and 250 who will pay anywhere from $0 to $16 per month for a median bronze, or between $0 and $72 for the second lowest costing silver. So these lower income folks also receive CSR subsidies, which increases the richness of their benefits to either a 0.94 AV, a 0.87, or a 0.73, depending on their income level. Prior to the passage of ARPA, enrollees at or below 400% of FPL, they were receiving premium subsidies, but the premium subsidies have increased greatly under ARPA for these enrollees.
Jen, this is Tiffany from the insurance department. I'm going to jump in because we have some questions coming in the chat that are specific to slides. So just for folks on the call, if I see a question that's specific to the slide, I'll try to capture your question during the presentation. So the first question is back to slide number 5. Can you just explain the benefit richness graph one more time?
Slide number 5?
25.
Oh, 25, sorry. Okay, yep. So we're in this chart, we're measuring benefit richness by the paid to allowed ratio. So how much is the insurance company paying versus how much is the total cost of medical care? So the higher the number, that means the more the insurance company is paying, and therefore the less the member is paying in cost sharing. So to be higher is better or more rich.
Thank you.
Okay, so now we're gonna move on to talking about some claims data and utilization data. So everything we've been looking at up to this point was related to premiums and cost sharing. So those are the costs that fully insured employers or consumers incur directly. But now we're looking at claims and utilization data, which is the actual experience that ultimately feed into the premium development. So trends in all market segments were negative in 2020, most likely due to the impact of COVID-19. The observed allowed claims per member per month trend in 2020 was minus 5.6% in the overall fully insured market and minus 7% in the self-insured market. The trends by market segment within the fully insured segment were fairly consistent at minus 5.1% for individual and minus 5.5% for the group markets. So we asked insurers about the impact of COVID-19 on their medical spend in New Hampshire, and there were several common themes. So all insurers saw a significant increase in telehealth visits and behavioral health visits in 2020. They all experienced overall claim suppression in 2020 due to COVID. Most insurers stated that utilization levels began to approach pre-COVID levels at some point during the summer of 2020. So at some point during the summer of 2020, things started to return to how they were looking prior to COVID. And lastly, most insurers stated that early 2021 costs were higher than what they would have expected pre-COVID. This chart takes the combined minus 5.5% small group and large group fully insured trend and breaks it into two components, utilization and cost and mix. So utilization is the number of services provided, and unit cost and mix are a combination of the change in unit price of specific services and the change in the mix of services or change in the mix of providers being used by patients. The utilization trend has remained did remain fairly level in 18 and 19, but then in 2020, we saw this significant negative utilization trend, again, most likely due to COVID. Now, the cost and mix trend is also lower than the prior year. So typically we try to, working with the insurers, break out how much of the cost and mix trend is unit cost versus mix. But given all the changes that happened in 2020 and the different impacts by insurer and by segment, it was difficult to come up with an approximate mix trend, and that's why you're not seeing it shown here. And as it relates to mix trend, insurers cited several different factors coming into play. So there were a decrease in elective services in some segments, and depending on which services those are, that could either increase or decrease the mix trend. There were more expensive inpatient and emergency room visits in some segments, so that would increase the mix trend. And then there was an overall increase in lower costing COVID testing services would decrease generally the mix trend. So there was a lot going on there, and it was difficult to really come up with a clear picture of the mix trend in 2020.
Jen, this is Tiffany again. I have a question coming in related to the claims and in fully insured market. The question is, if claims were lower by 5.6% in the fully insured market, why aren't we seeing premium drops of similar magnitudes?
I mean, the quick answer is because premiums are set in advance. So all of these insurers had to set these premiums in 2018 and 2019. And obviously at that point, no one had any idea that COVID was going to happen.
Thank you.
Okay, so as part of the annual hearing data collection process, Insurers provide average unit price changes or payment rate changes at the major service category level for the current year and the projected year. So this chart is an aggregation of that data for inpatient and outpatient facility combined in blue and for professional services in red for the past couple years. So this is showing that across all insurers in New Hampshire, average payments rates did increase going from 19 to 2020, and they're expected to increase again going from 2020 into 2021. So now we're taking that total PMPM trend in the group market and we're looking at it by service category for fee-for-service claims. Now, the percentages shown down below and by service category represent the amount that each of these categories contribute to total allowed spend. There were negative allowed claims, PMPM trends, in all fee-for-service categories in 2020. And within each of these buckets, it was utilization trends that were the primary driver of the lower trends in 2020 for each of the medical service categories. Now, negative trends for the medical service categories were expected due to the impact of COVID-19, but the negative pharmacy trend was not necessarily expected. The negative pharmacy trends shown here are primarily driven by negative cost and mix trends, and we're going to take a closer look at pharmacy in the next couple slides. Now, the other thing to note is that there are additional non-fee-for-service costs that are not shown in this slide, but they are included in the total allowed PMPMs that we looked at in the previous slide. So the non-fee-for-service claims include costs for capitated services such as behavioral health and for risk-sharing payments with providers. Non-fee-for-service costs increased from about $13 PMPM in 2019 to $21 PMPM in 2020. And the large changes are primarily driven by changes in provider risk-sharing payments. So now we're going to take a closer look at the pharmacy trends. Pharmacy trends in the group markets in 2020 were negative 2%. And this was lower, as you can see, than the prior year of 5.7%. So generally speaking, COVID-19 was not expected to impact pharmacy costs like it did medical costs. Insurers indicated that the reductions in pharmacy costs in New Hampshire are actually due to changes with pharmacy benefit managers, or PBMs, and/or rebate contracts that happened to take place in 2020. When examining pharmacy reports from two major PBMs, 2020 pharmacy trends across the country were in the 3 to 4% range. And another source documented that overall pharmacy expenditures in the US increased 4.9% in 2020 compared to 2019. So the trends that we're seeing in New Hampshire are well below these figures. Generally speaking, while cost and mix trends were negative for pharmacy, utilization trends were positive in 2020, and some insurers cited increased utilization in drugs related to antidepressants, ADHD, and other drugs related to mental health treatments. Now, specialty pharmacy shown here, their trends did come down a little bit compared to the prior year. They were at 12.7%. Now they're at 10.1%. But as you can see, their trends continue to significantly outpace trends in the generic and brand specialty categories. In addition, specialty drugs have become the major contributor to pharmacy spending. They represent 53% of total pharmacy costs. The right-hand side here, as we've done in the past, we're showing pharmacy drug PMPMs that are covered under the medical benefit, which includes prescription drugs that are administered at a physician's office or in a hospital setting. And in many cases, these are high-cost injectables. Now, these trends are lower in 2020 at 2.4% compared to the trend we saw last year at 7.9%. Throughout this report, the pharmacy information is presented net of prescription drug rebates. Rebates are the amounts which are paid to insurers or PBMs from drug manufacturers, reducing total pharmacy costs. Given the changes that we talked about with the PBMs and the new rebate contracts cited by insurers, prescription drug rebates grew at a much faster rate than pharmacy costs in 2020, helping to keep the pharmacy trend negative. In 2020, pharmacy trend's gross of rebates was 6.5%. And once you look at it net of rebates, like we shown in the previous slide, it's minus 2%. Overall rebate PMPMs in the group markets increased from $16 PMPM in 2019 to $25 in 2020, which is almost a 60% increase. About 51% of rebates were for specialty drugs, which is also an increase from what we saw in the past. Last year, about 45% of rebates were for specialty. So now we're shifting our focus a little bit to look at allowed claims trends in the individual market. Overall, allowed claim PMPM trends in the individual market were also negative in 2020 at 5.1% or minus 5.1%. We can see a lot of that's driven by the exchange market being the biggest segment within the individual market. And in the exchange population, we saw it's a similar story to what we saw happening in the group markets. There were negative trends in all service categories and largely driven by utilization changes. So also similar story with the individual markets is that we generally saw low or negative medical utilization trends, but there were also changes with PBMs that kept pharmacy costs low. This one segment, again, the grandfathered and transitional population, it is a small population where in the past year they saw a trend of 4%, but they also are negative at 4.2%. And then this non-exchange population, it is relatively small, and there's been a lot of shift in membership among insurers. But here their trend actually stayed fairly flat. So while they did see negative utilization in many service categories, the outpatient facility category is actually keeping this trend flat instead of negative. For the first time this year, insurers were asked to report on primary care PMPM spending by market segment for 2019 and 2020. Now, the NHID, we did not specifically define primary care for the insurers, but each insurer provided their definition of primary care, which was generally based on provider type and included providers such as general practice, family practice, internal medicine, pediatrics, and geriatric medicine physicians. The PMPMs by insurer were fairly consistent in the group markets, while there was a little more variation in the individual market. In each market segment and for each insurer, there was a decrease in primary care PMPM spend from 2019 to 2020, most likely due to the impact from COVID-19. On a percentage of total allowed claims basis, primary care spending represents about 5.5% in 2020. And this seems to be becoming, or primary care, it has been a hot topic for a while, but it's continuing to be a hot topic. And several states, including Rhode Island, Delaware, and Massachusetts, now have initiatives in place to increase primary care spending and/or to better measure and report on primary care spending. The last two slides in this section present some utilization data by market segment for two key utilization metrics: inpatient admissions and emergency department usage. All market segments experienced double-digit trend decreases in inpatient admissions per thousand from 2019 to 2020, with the largest decrease happening in the large group market at minus 13.9%. So the large decreases, again, are most likely due to the impact from COVID-19. Inpatient admissions remained higher in the individual market, the level itself, compared to the small group market, and just slightly higher than the large group market. Now this black line is showing the Healthcare Cost Institute's 2019 admissions per thousand nationwide based on employer data, and that's at 53 admits per thousand. So the small group market in 2019, you can see, is below this, this metric, whereas the large group market is slightly above it. Similar to inpatient admissions, emergency department usage decreased in all market segments from 19 to 2020, and in total decreased 17%, again, most likely due to the impact of COVID. All markets experienced double-digit decreases in emergency department usage, with the largest decrease happening in the large group market. Emergency department usage in the small group market has remained slightly lower than the individual in the large group markets. All right, in this last section of the report, we're going to talk about medical loss ratios and risk adjustment. So the risk adjustment program under the ACA is intended to redistribute funds from insurers with lower risk, healthier enrollees to insurers with higher risk or sicker enrollees. Health plans who have healthier members will pay money, and that's shown in red, and health plans who have sicker members will receive money, which is shown in black. And this is a permanent program that's revenue neutral within the New Hampshire individual market and separately within the New Hampshire small group market. Now this table is for the individual market. And here we're seeing that Matthew Thornton Health Plan, which is part of Anthem, was assessed or paid $17 million in risk adjustment for 2020. And that's fairly similar to what they paid the prior year. Ambetter or Celtic and Harvard Pilgrim were the receivers, and their the amount they received are fairly similar from 19 to 2020. The last column we have here is showing the payments and receivables on a PMPM basis, as opposed to the other column showing it on a total dollar basis. Here we show loss ratio information for 2020 for the individual market. Now the chart on the left has not been adjusted to reflect federal MLR rebate payments based on the 2020 federal MLR forms, while the chart on the right has been adjusted to reflect these federal MLR rebate payments. Now, federal MLR rebate payments from the 2020 forms are paid in 2021, and they include experience for the prior 3 years, so 18, 19, and 2020. Due to the federal MLR rebates formula's use of 3 years of data, insurers' experience from prior years continue to impact future years' calculation of the MLR rebates. Now, the impact of COVID-19 led to this 10% risk margin in 2020 prior to MLR rebates. But after accounting for the MLR rebates, the risk margin decreases to 2%. So these results indicate that the federal MLR policy appears to be effective in limiting insurer risk margins. Federal MLR rebates as a percentage of premium were 7.7%, or close to 25 million in 2020, which represents an increase over 2019, where the federal MLR rebates were 5% of premium, or about 16 million. After accounting for the MLR rebates, 73% of premium is paid toward medical and pharmacy costs in the individual market. Now, turning to the small group market, the total amount distributed from the risk adjustment program decreased in 2020 compared to 2019. So 4.7 million in 2020 versus the 7.4 in 2019. In 2020, Tufts Health Freedom Plan and Harvard Pilgrim Healthcare of New England were the largest payers, while Harvard Pilgrim Insurance Company received most of the risk adjustment payments. So this suggests that Tufts Health Freedom Plan and Harvard Pilgrim Healthcare of New England enrolled the healthiest risk in the market, while Harvard Pilgrim Insurance Company enrolled the least healthy risk. And this last data slide looks at loss ratios in the group markets for 2020. For both segments, the premiums have been adjusted for federal MLR rebates. Federal MLR rebates on a percentage premium were minimal in both of these market segments in 2019, while in 2020, federal MLR rebates as a percentage premium was 5% in the small group market and 4% in the large group market. This translates to $3 million in the small group market and $8 million in the large group market. Now, the risk margin, or the contribution to surplus in the small group market after accounting for rebates, was 4%. This is slightly higher than where it was last year at 3%. The risk margin in the large group market in 2020 after accounting for rebates is 3%, and this is slightly lower than where it was a year ago at 5%. After accounting for MLR rebates, 77% of the premium is paid toward medical and pharmacy in the small group market and 84% in the large group market. So this is our last slide, and it summarizes our key findings in New Hampshire for this year's report. So first off, the individual market experienced significant increases in enrollment in 2020, most likely driven by New Hampshire's state-based reinsurance program, along with the additional subsidies due to ARPA and the extended special enrollment period. Small group market enrollment continued to decline into 2021. Overall, New Hampshire commercial situs enrollment has decreased slightly over time, while Medicaid enrollment has continued to increase significantly. And COVID-19 had a significant impact on medical claims and trend in 2020. Unit cost trends are expected to increase into 2021. Insurers in New Hampshire indicated that pharmacy reductions in 2020 are due to changes with their pharmacy benefit managers, PBMs, or rebate contracts. And lastly, federal MLR rebates increased in 2020, thus decreasing the insurer risk margins. So as the commissioner mentioned, the full preliminary annual hearing report is available on the NHID website, which provides more context and additional information beyond what I presented here. And we would also like to greatly thank the NHID staff and all of the New Hampshire insurers in their efforts in providing the data information that we use to put together this presentation and the report. And now we have some time for some additional questions. So I believe folks are continuing to maybe put those in the chat, and either Dawn or Tiffany are going to read the questions, and I'll do my best to answer.
Thanks, Jen. Yeah, hi, this is Don from Gorman Actuarial. I do have some questions that were provided in the chat, and a couple of them, the first couple were asked by Mark Galvin, and those are more towards transparency. They don't really relate to Jen's presentation, so I'm going to push those to the next panel, which actually focuses on transparency. So the next one that wasn't answered during your presentation, Jen, is a question from Lucy Hodder. I think it's due to on slide 22, so if you can flip back to that one. And I believe she's asking specifically about the COVID premium credits in 2020. And the question she asks is there a summary of all the premium credits given out in 2020 by New Hampshire carriers, or is it in aggregate? Is that available?
Good question. I believe in the in our actual report, we talk about total, or we can add that. And I believe that information is publicly available, but I might refer to the NHID where the best place to find that is by carrier.
Okay, sounds good. All right, so the next question was from Cynthia Bell. I believe it's on slides 31, 32. She asked for a definition of professional services, and I can handle that one, Jen, unless you want to pipe in afterwards. So basically, when we set out the data request to the payers, the carriers, we defined professional services to include claims based on non-capitated primary care, specialists, therapy, and the professional component of laboratory and radiology, and other professional services.
Yep.
Okay. So the next question is also by Cynthia Bell. It's on slide 36. And when we talk about primary care spending, what is the motivation for states to increase primary care spending?
Well, I think the general thought is that if there's more the primary care, if folks have better access to their primary care and the primary care physician is able to better manage their care, it will avoid other services downstream. So whether it's additional specialists, additional admissions in the hospital. So the thought is to, I think it's a national initiative really, is to investment in primary care will help avoid other costs in other areas.
Okay, I just noticed that the links to the documentation has also been provided in the chat, so you can click on that. The preliminary report is on the NHID's website. It will be finalized, as the commissioner mentioned, in December. But that report has all of the slides that Jen presented today. It might not be in the same order, but they are all there. And I think the last question we have is also from Cynthia Bell. It's about she's asking about how the PBMs on slide 30, I think 38 or so. We talk about what specifically changed with PBMs that decreased the pharmacy cost.
So typically, most of these insurers work with a PBM to manage their pharmacy benefit. And, in my experience, insurers typically, every 3 to 5 years, they renegotiate with their PBM, they put it out to bid. They, so it's a very intensive process to figure out who they're going to work with their PBM. So it just so happens in 2020, several of the New Hampshire insurers went through that process and either renegotiated with their current PBM or switched PBMs or changed their rebate contracts. So typically when that happens, it can greatly impact the pharmacy spend, because whoever that new PBM they're working with or the new contract, they provided additional discounts or additional rebates on drugs. So it can, because several of them did this in the same year, we saw these favorable impacts in 2020. But this is a typical process that happens between insurers and PBMs every couple of years or so.
Great, thanks for that, Jen. I don't see any other questions, and we're at 10:08, so I think we had a scheduled break for a couple of minutes, and then Tyler's going to kick it back in with the next panel.
Sounds good, thank you.
So I want to thank you both. We're going to start promptly at 10:25 with the transparency panel. Jen and Don, thank you for your time.
Thank you.